We're going to kind of dig in here a little bit, get started. And first, I have nothing to disclose here today with respect to C4. It's a little different in a webinar. Usually I'm kind of a in front of the audience type of person, but I really believe that this is something that we learn together, okay? So, you know, make sure that you have some questions you're jotting down. I'd be happy to share some of those as we move along here, or at the end, excuse me. Now, how did I get here? How did this whole thing start? It really started with this idea of just connecting the dots, because when we speak about addiction, there's so many things that come into play in that conversation, right? And I like to take a look at the literature, as practitioners do. And interestingly, when a piece of literature in the medical literature really is prescient, really rises to the top, at least in the eyes of the media, it gets sort of some play in the secondary press. And by that, I mean, it may hit the journal like the Lancet or the British Medical Journal or New England Journal of Medicine, etc. And then it gets picked up and it gets spread into the print media or journalism. And this is one such article that caught my eye. And this is from the University of Michigan Science Daily. But the authors here, the tagline was, "Opioids fueled a doubling of suicides and overdoses in the US." Now, I think it's a good study. And I want to pick it apart here and go through it, because I thought, you know, we sort of know this, right? I mean, is there anything new here? And what might we be missing? The authors came up with some good data, though, and we showed that deaths from both unintentional overdoses and suicides combined rose from 41,000 in the year 2000 to 110,000 in 2017. That's a significant jump up, and that has to be something that we pay attention to. Additionally, the rate increased by double, right? So we see that suicidality has increased double in that amount of time, and that opioids were implicated in 2/3 of unintentional overdose deaths and 1/3 of all overdose-related suicides. So, you know, it's a sad article, it's an important article, it's a compelling journal article, but here's the where I start to pick it apart a little bit, okay? The authors went on to talk about, is this the supply or is this the demand? In other words, how do we get here? Why are we talking about this? Well, the first theory that they espouse is that perhaps both overdose and suicide represent this death of a psychosocial despair, right? And that opioids in this theory are seen as just the coping mechanism. In other words, we use this to self-medicate symptoms of anxiety and depression and hopelessness, all types of feelings that people are unable to deal with, right? And so the opioids are seen in that symptom as just something that is a symptom of a larger illness. And so perhaps the opioid use disorder itself makes both overdose and suicide more likely, okay? So theory 2, however, is that perhaps it's the availability of all the opioids. If we didn't have so many opioids being written and prescription medications, or flooding over from China and from Mexico, the increase in heroin and fentanyl and the increase of OxyContin, then perhaps we wouldn't see this uptick in overdose and suicidality related to overdoses, to opioids. And so the theory for this is bolstered by the fact that we've seen this in the past. For example, crack cocaine. I mean, if we didn't have crack cocaine having been developed in the 1980s and 1990s, we wouldn't have had a crack cocaine problem, because it was a new drug. It was a new type of substance that had been introduced to the American population. Now, both of these have merit, and I think they're worth looking at. But my question here is this anything new? Because in point of fact, we know that suicidality is rising anyway. And so other data tells us that from roughly the same period of time, from 2000 to 2016, suicide rates increased for males and females. And this really took a bump up in the last, say, now it would be 13 years, but the last 10 years of that survey. So the age-adjusted suicide rate increased 30%. Now that's also significant. Now this is carved out from any association with opioid use, okay? So why is that important? Well, look, we know that opioids are an important topic right now because the opioid epidemic is literally taking the flower of a generation. And so what does that look like in America? Well, let's just talk about that a little bit. You know, the Center for Disease Control, Surgeon General Office, and the National Institutes of Health have all stated that we're in the midst of an epidemic. And they don't use the word epidemic lightly. In fact, it's the Center for Disease Control that really puts the stamp on is something an epidemic or not. And not everything rises to that level. We willy-nilly that term and throw it around, but to actually be an epidemic, we know that we have an increase in the rate and the incidence and prevalence of the use of opioids in America. And it's an important topic because, in point of fact, the impact is huge. The most recent data, and I'm kind of a nerd about this, so I look at this stuff a lot, and from the Center for Disease Control, in 2017, we had more than 47,000 Americans that died of an opioid overdose. Now, I want to talk about that statistic for a second because you'll often hear people say, hey, there were over 70,000 drug overdoses in America in that year. And that's true. But if we carve out the data, roughly 47,000 of those were attributable to opioids. Now, that's a significant amount of people. That's 130 people that die each day in America from an opioid overdose. Think about it this way. If we lost the equivalent of, say, a jumbo jet crashing in America every day, that's the impact that this has on the loss of life. But we don't see it that way because these are people dying throughout our communities, throughout the country, oftentimes nameless, almost faceless people to the rest of America. All their loved ones know. The people impacted in their community know. But we lose the forest for the trees, the impact of it. But listen to this, it's 5.4 persons an hour. Now we're going to talk for about an hour today. A little bit extra time for questions. We'll lose 5 to 6 people during the time that we're talking here. That's about every 11 minutes a person dies of an opioid overdose. Now, initially, when we spoke of opioids, in this country, we talked about physicians and overprescribing, and there's a complete story and a narrative about how we got there. But physicians listened, and there's in fact been a significant drop in prescriptions being written. And this is kind of a busy slide, but this comes from the AMA Opioid Task Force, and their work showed that there had been nearly 1/4 decrease in opioid prescriptions that were written between 2013 and 17. So in point of fact, healthcare prescribers are listening, and this is being tightened up. And yet during that time frame, we still see a problem with opioids. Well, why is that? Well, in part, we know about fentanyl. That's another topic, but it's a big topic, and it bears some mention here because fentanyl entered the scene and is so incredibly potent that it's killing people at a dramatic rate. This is a slide that I really think is impactful and powerful because this is testimony that Kirsten Nielsen did. And again, this is very recent data. This is her information rather. This is from March of 2019. And essentially you can read it there, but ICE interdicted enough fentanyl to kill every American twice over. every man, woman, and child in America twice over in 2018. And that is a frightening statistic, in fact. And what does that look like? It looks like this slide. If we see wave one, there was a rise in prescription opioids and overdose deaths. That's flattened. The yellow line represents the rise in heroin, largely black tar heroin that entered the marketplace because it became difficult to get the prescription drugs, frankly. And now fentanyl has been the game changer. And in this third wave, the dark line, we see just this hockey stick effect that the death from synthetic opioids, most specifically fentanyl, has become devastating and carving out communities all over the country. And, you know, people ask me this all the time, why? What are the hows and whys of this? And the hows and whys of this are probably a couple of things. Fentanyl entered into our marketplace largely because once people become addicted to heroin, they're usually using not to get sick after a fashion. They're using just not to go through the withdrawals because they're dependent. That's the definition of the dependence, really. If I don't take it, bad things will happen, and specifically withdrawal. Now, it would also get, our patients could get high from using it, right? Users could get high by the introduction of fentanyl. That wasn't happening with heroin after a while, and that became a game changer and for people who were using drugs to do exactly that, to get high. But 1 kilogram of fentanyl can be purchased directly from China. Fentanyl analogs can be purchased directly from China. This fentanyl, the kilogram of fentanyl can be bought for about $5,000, delivered to your door like Amazon. And it's crazy scary. And then it's repackaged and sold for about 1.5 million in street value. That is significant, and that's very, very difficult to treat or to get a handle on and get ahead of, because you don't need poppy fields, you don't need AK-47s, you don't need a dangerous supply route. It just gets delivered from China, and so it's a difficult thing. There's a great book called Fentanyl Inc. that I would highly recommend people go take a look at if you're interested more in how this is happening. Likewise, Sam Quinones' Dreamland, 2 books I really recommend that talk about how we got to this place with the fentanyl the opioid epidemic. And again, we're losing so many people to opioids. And I start with the opioid epidemic because we hear so much about it and people try to wrap their head around it. The authors where I started said the hows and whys of, is it the opioid epidemic itself, just the presence of the opioids that are causing this? If we didn't have all these drugs, would we not have all these drug deaths? In part, probably so. But why do we have all these drugs? Why do we have people using these drugs in such a dangerous, illicit, persistent manner, an addiction? Is it because we're covering up the despair that many people have that's untreated? Probably partially so. And we are indeed losing the flower of a generation. But it's not just about opioids, because if we really look at addiction in its totality, alcohol still remains the most dangerous drug in America. And switching gears on that a little bit, it's important to remember that alcohol kills more teenagers than all other drugs combined. And it's a factor in the 3 leading causes of death: accidents, homicides, and suicides in the emerging adult population. The bulk of people who receive treatment for substance use disorder come to places like Sierra Tucson, where I'm at, or all the many other places in the country, for alcohol use disorder, at least as one of the primary drivers. So alcohol kills about 88,000 people a year. Now that's in 2017, the same year we had the data on the opioids, opioid deaths that I just spoke about. Now I think that data is a little soft because that data has been around for a while and I follow this. So in all likelihood, alcohol is killing more people than that. But as it is, that statistic makes it the 4th leading preventable cause of death in the country. Okay, that's significant and cannot be ignored. So where are we at with this? We know that alcohol and drugs of all types, not just opioids, increase suicidality. And this is older data, but it tells us the trend that compared to the general population, persons who suffered from substance use disorder had a significantly increased risk of death by suicide. That 22% had alcohol as an intoxicating factor. Opioids were present in at least 20%. And again, this is 2004 data. We've seen that rise. Marijuana present as a factor in about 10%, cocaine, amphetamines, etc. The bottom line is drug use is associated with increased suicidality. And that's not new to the opioid epidemic. So how do we untie this Gordian knot? And how do we pull this together? We have substance use disorders, we have overdose, we have suicidality, all on the increase in this country. Is it the presence of the drugs? Is it the presence that we've always had of alcohol? What is it that's causing and driving this? And it's important that we change our thinking about this because physicians have responded. It may sound protectionist, it's not meant to be, but the medical community has said, yes, we need to rethink how we're prescribing prescription opioids, how we're treating chronic pain, how we're treating acute pain. We have to think about things like with drug courts and how we're dealing with getting people into treatment, and yet the problem persists. And switching gears a little bit then, to tie this together, in full disclosure, in my old life, I was an anesthesiologist. I tell most of my patients at this juncture, I'm in recovery. You can do the math. I work in addiction medicine now, and I'm pretty open with my patients about that. But it means, in a way, I look at things somewhat differently. So, trauma, as is practiced inside of a tertiary care hospital, is about people getting shot, stabbed, car accidents, and there's a really important lesson to learn here. There's a thing called the lethal triad of trauma, and we recognize that as being cold or hypothermia, coagulopathy or inability to clot well, and acidosis. Now, how does this relate to mental health? Well, here's how. Look, inside of this lethal triad, if this isn't treated, there's a 44% mortality. The acidosis in particular is an interesting one because that's where the blood becomes acidic. Well, every surgical and anesthesia resident and trauma nurse knows that if we put, essentially, it's like baking soda, sodium bicarbonate into the bloodstream, it shifts the acid-base balance back into a more basic place. But it always shifts back to the more acidic place unless we treat the underlying cause of the acidosis. What's the causative factor? Or as we say here at Sierra Tucson, where's the fire in the basement? And so the analogy really becomes psychological trauma and emotional trauma. And that's the thing that's all too often that is left untreated in our patients when we're talking about substance use disorder, anxiety, eating disorders, process disorders, chronic pain, all types of ailments which affect individuals in this country on a great scale. Now, one of the things that we've learned in the past several years is how significant developmental trauma is. Now, I don't have my audience in front of you, so you can all kind of ask yourself the question. When I have a live audience, I talk about the adverse childhood event testing and the ACE scores and the ACE scale, and I ask how many people are using this in their practice as a way to open up a dialogue. And I have to tell you, unfortunately, not a lot of hands go up. I will say in my own practice and here where I work at Sierra Tucson, we started using the adverse childhood event scoring scale during the past year, and it's been very impactful in helping us identify and really open up a dialogue about what trauma may have occurred in childhood. Because I'll have patients who come to us for treatment here who've been to many, many treatment centers in the past. And the thing that they often tell me is, yes, but I never dealt with the trauma, even in places where it's trauma informed. I mean, what does that mean to be trauma informed? And I would posit it's this, and let's go through it. Looking at what the ACE study is means looking at what developmental trauma is. So the story goes like this. Dr. Felitti, who was at in the Kaiser Permanente system in the San Diego area, had this patient, and she was there for his obesity clinic where he worked. Now, the thing is, she did very well in the clinic, and she lost over 100 pounds, according to the memoir that he wrote there, his memoir-like writings that he wrote. So he's talked about this event. He said, hey, listen, I want you to go away and try this diet on your own, and I want to see you again in about 3 months. So she comes back in something like 3 months, and she's not only gained 100 pounds back, but 50 beyond that, 150 pounds heavier. And he said, what happened? You were doing so well. You had the diet, you had people you could call, you had the support network, all the things we set you up with. And she said, I know, Dr. Felitti, but I met a guy. I don't understand. You met a guy. That's a good thing, right? She said, yeah, but he loves me, and he's talking to me about marriage and a future. And he said, you're going to have to fill in the blanks. And she finally said, I was raped when I was a teenager. I've never had a lot of attention from men when I was heavy. And this had memories that I didn't know how to deal with. It just came rushing back in that I wasn't even aware of. Now that was significant. And he knew this. And he recognized with foresight and to our great delight that he had a piece of data points that were in front of him that he could tap into, that being one of the largest public health cohorts in the entire country in the Kaiser Permanente system, is specifically in the San Diego County area where he was at. Now, what he did with that is he got together with Dr. Bob Onda and from the Center for Disease Control, and they ran a study called the Adverse Childhood Events Study. And what we know about this is that they studied about 17,000 patients and found that there were some significant things that happen when people's ACE scores went up. So how does this work? The ACE score is done on a scale of 0 to 10. Now it's been expanded, and we do a more expanded version here up to 14. Now these are not the normal, oh, I got picked last at recess, or I wrecked my bike, or things like that. These are significant things such as sexual abuse, emotional abuse, physical abuse, abandonment issues, mental illness or substance abuse in the family. And we learned something important, that they're very common, and roughly 2/3 of all Americans have a score of at least 1. And if you have a score of 1, then you're about 87% more likely to have a score of 2 or more. So we did these 10, they did these 10 questions and found that it was a dose response curve. What does that mean? Well, in other words, the more trauma a person had in their childhood, the more likely they were to go on and have problems. So the problems that we saw were substance use disorders of all types were significantly higher in individuals with a higher ACE score. Suicidality, higher in people with a higher ACE score. The higher the score, the higher the incidence of suicidality. Depression, tobacco use, increased sexual partners and STD exposure, obesity and sedentary behavior, domestic violence. They were more likely to go on and engage in domestic violence if they had been a victim of domestic violence. Engaging in abusive relationships, very similar to what I just said. It puts people at risk for engaging in behaviors that are deleterious to them later on. But this is the thing, chronic disease of all types, including coronary artery disease, lung disease, cancer, liver disease, skeletal fractures. What? How does that come into play? And we'll talk about that because that's important. So this is a busy slide, and we'll go through it kind of quickly here. But for those of you who have not done an ACE test, and again, I don't know, because it's the webinar, I don't know who has or has not, and I'm assuming some of you have, but let's bear with me here because I think this is important stuff. Did a parent, so this is the actual ACE test. Did a parent or other adult in the household often or very often swear at you, insult you, put you down, humiliate you, or act in a way that you might be physically hurt? That if you answer that, that's a score of 1. Every yes question is 1. Did a parent or other adult in the household often or very often push, grab, slap, or throw you, or make you hit you so hard that marks were left? Were you sexually abused by a person who was 5 years older than you? Okay, that's important, and it moves into some specific items that might have happened. Did you often feel or very often feel that no one in your family loved you, or thought you were important, that your family didn't look out for each other, feel close to each other? On this issue, this is something where I allow for nuance with my patients. We'll talk about that, and they kind of hesitate. Well, what does that mean? I don't want to force the fit, bang a square peg in a round hole. But understand if there's an issue surrounding that the ACE test doesn't have to be all-inclusive. It's a starter point. So did the patient feel that somehow there was something awry with how love was shown in the family in a significant way? And moving on, did you often feel that you didn't have enough to eat, that you had to wear dirty clothes, similar to number 4? Were your parents separated or divorced? Was your mother or stepmother often or very often pushed, grabbed, slapped, or had something thrown at her? Now, we say this as a mother or stepmother. It could be a father, but we found that it was significant because a lot of women were victims of abuse, and the kids watched that. And did you live with anyone who had substance use disorder? Was there someone depressed or mentally ill or attempt suicide? And did a household member go to prison? That's a big, busy slide, and it's a heavy slide, because what I find is difficult about this, when we open this up here and I talk to my patients about this opens up a lot of emotional doors. And in point of fact, while there's a lot of talk about the ACE test inside of conferences and gatherings of mental health professionals, I'm still finding people aren't using it. When we can open this up to our patients, now understand, it's not a diagnosis of PTSD. It's a risk indicator, but it's an important risk indicator, because what we're doing is we're opening up this idea that the trauma is something that we've lost through shading it over in our head, concealing it through shame and substance abuse, and we keep it secret and we don't discuss it. It's important because we found that individuals who had a high ACE score, such as a score of 4, were 7 times more likely to suffer from alcohol use disorder. Now, how significant is that? Well, a score of 4, that's 1 in 6 Americans. So let me say that a different way. 1 in 6 Americans has a 7-fold increased incidence of alcohol use disorder. And they have a 12-fold increased incidence of suicidality. As that ACE score rises, say up to a score of 6, the likelihood of IV drug abuse rises to 4,600% over the baseline, right? So if you have a score of 0 versus a score of 6, your increased incidence of IV drug abuse for the score of 6 is enormously higher. And suicide attempts increase about 5,000% with scores that are advancing from 0 to 6. So if you have a score of 4, you're about 12 times more likely to commit suicide than a score of 0. If you have a score of 6, you're about 50% more likely to commit suicide. than a score of 0. These are important statistics because the ACE scores are simply so, the idea of these childhood traumas are so pervasive. It's quite frankly a crisis that we're not really quite addressing in public health. But we talked about the chronic disease, and I hope you see this well at home. This actually is one of the slides that this Center for Disease Control uses. It's from their website. As we see this pyramid, this pyramid with the adverse childhood experiences at the bottom, and we see the things that, and therapy, and as physicians, we know disrupted neurodevelopment, the social, emotional, cognitive impairment. Now we're getting into the adaptation of health risky behaviors. So what does that mean? That means substance abuse. That means anxiety. That means people who aren't taking care of issues that they should take care of. ADHD, maybe they're self-medicating, and maybe they're self-medicating anxiety. Maybe they're escaping and isolating from difficult home situations or work situations where they haven't gained the ability to regulate and emotionally navigate through what should be a good career, a college experience, life experience, family, raising children. Ultimately, this leads to disease and disability and social problems and early death. In fact, a score of 6 produces an average decrease in life of 20 years amongst adults. Now, that doesn't mean that everybody who scores a 6 can just knock 20 years off their life, but it does pull the average down because of the increased risk of problems with health. Now, I love this quote from Teddy Roosevelt. I bring this out and I keep bringing it to audiences, and I'm heartened that people listen, and yet surprised, somewhat discouraged sometimes that people haven't taken the idea of the ACE scores and or trauma work and moved it into their practices. And if there's one take-home point that I want to make today, it's understanding how impactful pervasive trauma is as a child into further traumas as an adult because of risky behaviors that are often repeated, because people who've experienced emotional and physical abuse in the home are more likely to reproduce that later in life. Sexually abused individuals are more likely to go and engage in risky behaviors. For example, and we think this is something we don't talk about, 1 in 4 American women is a victim of sexual abuse. 1 in 6 American men is a victim of sexual abuse. So these things that we don't think are there, that we don't talk about, they're important, and we should talk about them. They cut across all racial lines, all socioeconomic lines. You may say, well, those things happen, in difficult family situations or lower socioeconomic classes. In point of fact, when they did the ACE studies, it was roughly 70% Caucasian, middle-class, college-educated individuals in San Diego area. And we know that it extends out across throughout the rest of America. The impact is huge. So when we really start to go back to this idea of connecting the dots of why do we have an increase in opioid epidemic? Why do we have an opioid epidemic? Why do so many people die from alcoholism consistently? Why are we seeing a rise in problems with cannabis in this country? Now we have meth 2.0. We have designer drugs. We've ushered in the idea that we can just bring in fentanyl overseas from China to your door or to the door of a dealer, be cut up, be redistributed. Well, the evidence, and it may not be comfortable and perhaps arguable, but I find it clear that people that are dying of overdose in this country are largely dying of trauma. And the statistics support that. What we're dealing with are issues that happened maybe 50 years ago, according to Dr. Felitti. We're treating those things now, but we're treating, as you see in the little diagram I put in the lower corner there, that we're thinking about that child who's still suffering the slings and arrows of childhood. And we don't talk about it. We don't talk about it in families, and we try to talk about it in therapy, but are we talking about it in the right way? Are we opening it up and saying, what's going on with your trauma? I'll give you a case in point. I had a patient in my practice. He had undergone a significant trauma as an adult male, and then went on to try to recreate that trauma. And it was sexual in nature. He tried to recreate it multiple times. By his own account, he had been raped about 200 times. That's a lot. And I question it only in that I think it becomes very difficult to actually keep count. And that alone really rose to a level of a PTSD diagnosis when we looked at all the DSM-5 criteria. However, it's important to note that not all people who suffer from developmental trauma, in fact, most don't, will rise to that level of PTSD, of having a diagnosis of PTSD. But this individual, when we traced it back, we could stop right there at the trauma. But when we trace it back, he had childhood sexual trauma and abuse that was significant and real. And it began to make more sense as to how he had engaged in this type of behavior and kept engaging in this type of behavior, which led into a significant substance use disorder. And that's what I mean by talking about this. We need to open this up. So how does this look inside of the brain of our patients? Because we talked about a few things there, many topics there, I know. Let me pull a few together for us. One thing we talked about is this idea of the chronic disease, and we talk about it in relationship to trauma. So inside of this thing we call the hypothalamic pituitary adrenal axis, right, or the HPA axis, this is where our stress response lives. And this is related to a sympathetic nervous system response, a thing we call fight or flight or freeze. And really, let's stick with fight or flight for now, because when we activate that, that's the part that says our heart rate's up, our blood pressure's up, our pupils are dilated. I've got to defend myself. I need to take care of business, whether that's defending myself or defending someone else or protecting myself, or I'm going to run, however it looks. It's an important part of our kind of lizard brain. That's that white part in the slide there that looks like a little fist rising up, and it's really connected right down to the spinal cord. It's all that nice pinky stuff on top. That's what makes us human, especially the things up front, that prefrontal cortex. That goes offline to some degree when this is happening. And it's down here in our limbic system, the lit up area, the reddish and whitish in this slide. And this is where we see that under our brainstem, the limbic system is so important for modulating our emotions, for our dopamine reward pathway that's involved with the mesolimbic pathway in addiction. And also, as it would turn out, as a big part of understanding and modulating memory, including traumatic memory. So how does this look, this stress response? So here's the analogy I always use here in Tucson. So you're walking along a path here in Tucson, and maybe you're out for a little walk or a hike, and you see something long and skinny in the trail, and you go, oh my gosh, what is it? Well, this visual stimulus comes into our brain, shoots around through our eyes, back to the optical area, and eventually goes to the clearinghouse called the thalamus, right? You see it down there in the blue oval. The thalamus's job really is to say, hey, look, we have information. What are we going to do with it? So it sends it off to our friend, the prefrontal cortex. That's the executive branch. They're going to do what executives do. They're going to think about it and form a committee and discuss whether it's a snake, whether it's a stick, what is it? Is it moving? Does it rattle? Does it look like something we've seen before? But the thalamus has to get it off its chest, and it sends it right next door to its busy little neighbor, the amygdala. These two little guys, which we refer to in the singular, are two little almond-shaped nucleuses our neural structures deep inside of our brain. And it's important because these modulate fear and anxiety. So how does this look? Well, it bangs around through the amygdala, and the next thing you know, it just quickly sends out an impulse into the sympathetic nervous system saying, hey, you know what? I'm sure this thing's a snake. I'm sure it is. I'm sure it is. Let's just go. Well, our heart rate's up. Our blood pressure's up. We're in fight or flight or freeze phenomenon right then. Now, in the meantime, the prefrontal cortex, back to our story, has said, it's a stick. And it sends it down to the hippocampus and into the amygdala and says, calm down, it's really just a stick. But that sympathetic nervous system is already increasing, it's already going. And what does that mean? Well, it means that the adrenal glands have kicked in and they've released adrenaline, which is also called epinephrine, norepinephrine. These are inflammatory substances. And that's an important point, because it also releases something called cortisol, which is an anti-inflammatory substance. It's beautiful how the body does that. You got an inflammatory substance, the anti-inflammatory substance, and it mitigates the effect. But what happens when there's a snake living in your head all the time from past life trauma? And it's not just this instance of maybe something in real time just happened. There's really something long and skinny in the trail, but we live with those types of responses, such as someone who has memory of stress, memory of, of trauma. Well, that stress, that toxic stress, it changes because we find that the cortisol can't really keep up. We call it cortisol failure. So that natural anti-inflammatory effect is no longer mitigating the inflammatory effect. And this is one reason we see negative things happen in our vascular system, on major end organs, and our joints that cause autoimmune disorders and vascular disease and all types of other chronic illnesses. That's where that reduced life expectancy comes from. So that's an important point, okay? Very important in terms of how this stress affects us. Long term, it can affect our DNA structure in a way that the epigenetics, in other words, the things around the DNA, are affected. What does that mean? Well, epigenetics, kind of a different topic, but in brief, we find that we carbonate or methylates, more specifically, our genes, our DNA. And what does that mean? Well, it means that it turns on the DNA in a different way. It doesn't change the DNA structure, but that toxic stress begins to affect how we present ourselves genetically. And that can be passed on. We estimate now about 3 generations. That has to do with this idea of perhaps generational shame, generational trauma. There's science behind that. It's not just a theory. So we know that that can happen, and if we're continuing in that behavior, those epigenetic tendencies, they can contribute and to the next generation and be perpetuated. Never changing the DNA, but changing how the DNA expresses itself through increased anxiety, depression, the traumatic type of thinking and shame all seem to be easier for those individuals to fall into because of the family dynamics. So this is the nature and nurture argument. Is it nature? Is it nurture? It's both. I think the argument's over. It's always both. But the toxicity of this stress is really important. Excuse me, I jumped ahead. And this just goes back to show, you see that little bitty red thing in there that I always think it should be in red, because I call it the angry little amygdala. You know, before anybody leaves against medical advice, I always say before there's an AMA, there's an ALA, an angry little amygdala. And it's very important to work on this area through mindfulness and ideas of shifting blood flow away from that amygdala area. This is one reason we think meditation works. Shifting blood flow from the amygdala area up to the prefrontal cortex, where we can think in a more clear and cogent manner. It's not so emotive, it's more rational, it's more values-based, it's where problem solving and decision making live, versus this lower amygdala hub which is where the emotive responses live. So how do we really rethink this? Well, we rethink our treatment in a few ways. We need to recognize that we need to be aware of what is causing substance use disorder, anxiety, depression, the effects of toxic stress long-term that trauma induces upon a family structure, upon our social structure. We need improved awareness as clinicians and as individuals. I think there needs to be routine screening for this ACE by primary care physicians and therapists. I mean, ask yourself this, for those of you who have been to a therapist in the last year, how many of you got asked about this? For those of you who had a physical, how many of you were asked, well, how's your trauma score? I mean, we screen for everything else. We screen for cholesterol. We check your blood pressure. We check your weight. We'll draw labs and look at your liver enzymes and your electrolytes and all types of other things. But do we talk about something that we know is statistically significant in causing and relating to chronic disease? The truth is, it's a rhetorical question because it's just not happening. So there's not enough resources for true trauma-informed care. People ask a lot about that. What are the resources? Well, SAMHSA has a great website that talks about trauma-informed care, and that's the place I usually direct people to first and foremost. Second of all, if you're in a practice, this information that I've just given you hopefully can help shape some of that practice. Again, we actually use the ACE study. We bring it out as a talking point with our patients. We don't make a diagnosis because it's not a diagnostic tool. It's a risk screening tool, but it's important to know that it's a tool that you have. There needs to be, and I can't stress this enough, more integrative care models which support holistic treatment. What do I mean by that? Because some of those are buzzwords, at least has used. Integrative care is, we don't really see the physical needs of the patient and the mental health needs of the patient as being two separate issues. They're intertwined. The last hour we've spent really shows how they're intertwined physiologically and emotionally, psychologically, socially, and in terms of the family and in terms of our work life and in terms of how it manifests in so many ways, you know, going to school, trying to succeed in whatever our endeavors are. So we need to really look at the mind, body, and spirit. When I talk about holistic medicine, when I talk about integrative care, that's what we mean. We need to also recognize the integrative care, which again is a buzzword. It can get a little sloppy around the edges. Is also about making sure that we don't say, well, let's just treat the depression, or let's just treat the opioid use disorder, or just the alcohol use disorder as standalone items. They're integrated. And we need to treat both effectively and efficiently at once, holistically, and looking at the mind, body, and spirit. That's an important point. Addiction treatment is trauma treatment. Developmental trauma, this is huge, deserves a diagnostic code. That's more of a lobbying point, to be quite honest with you. But right now, developmental trauma does not have a place in the DSM-5. And it probably, I think it should. I think it bears, both we've learned nothing else in the last hour, there's a significant issue afoot in childhood trauma that does not necessarily meet the criteria of PTSD, yet leads to so many other health issues and mental health issues. And so this needs to have a code. Why? Because we need to have an accurate diagnosis that we can all talk about in the same language, because it's very difficult to treat a disease unless we actually have a diagnosis to give that disease. So that's just basic medicine, and I would really advocate for that. So in the depths of our winter, I finally learned that within me there lay an invincible summer. I love this quote, and I put it there because it really helps to talk about what it is we're trying to help our patients find. But I would posit that it's very difficult to find that unless you know what it is yourself that you're trying to look for in that patient. We need to heal their broken spirits in order to address these public health issues. It's important. We have to understand what the antecedents and the comorbid factors of substance use disorder are. I'm an addiction medicine specialist, so I think a lot about substance use disorder. But I think hopefully I've come across in the last hour that you recognize that I see substance use disorder as many things. I tell my patients it's never the one thing. It's always all of it. It's always all of it. So the antecedents and the things that are happening at the same time are things like ADHD, like anxiety, like depression, but also very much so like trauma, which is huge in this country, pervasive in this country, pervasive throughout the world in terms of what we're able and willing to talk about as a society. And until we're able to have that discussion in a meaningful way, in a trusted manner, in a place, in a therapist's office, in a treatment center, in a physician's office, where our patients can open up and talk about the things that are truly bothering them, it remains shrouded in secrecy, a cloud of despair. So we need to recognize that this is underdiagnosed and it's very pernicious, and that developmental trauma, which often leads to PTSD and or the PTSD itself, that trauma is significant in dealing effectively with substance use disorder. And this is so important. This is another one of those take-home points. Our patients are individuals with a disease. They are not a disease to be treated. So I do say, yes, we need a diagnosis, but always remember, they're not a diagnosis. There are patients. They're individuals. Think of it as somebody's loved one, right? And that could be your loved one. So this opens a dialogue, if we do this right, that's meaningful and it addresses these issues. And it's out of these intense complexities that the intense simplicities emerge. When we connect these dots, it finally starts to make sense to us. So there's a lot to that topic. I enjoyed giving it, and I hope you found this helpful. I want to open this up to questions. We have a few minutes here, and so let's see. I'm going to pop this up for Q&A. I'll give this a second. I don't know if anybody's typed anything in. I will, while I'm waiting here, tell you the questions that I normally get. And I try to answer the questions as we go. But one is, what are your resources for trauma-informed care? And trauma-informed care has a lot to do, it becomes kind of a buzzword that everybody talks about, but is, again, making sure that it's integrated into the model of treatment that people share and that with their patients, and that means opening it up to a dialogue that's important. And this is from, we have our first question, and oh, that's a good question. Yeah, it says, Dr. Sansom, and she says, brilliant webinar, thank you very much, as kind words. Do you also include the resilience portion of the ACE study? And you know what, no, I do not, and that's a very good question. We deal with what we call the extended ACE study in our and the information we use, and so we have about a 14 question ACE study. One of the things I like about that 14 question, I'll kind of tangentially go off on this. I will say that I had a patient who came in who grew up in war-torn Bosnia, and every night the shelling, the grenades would go off, the shooting would start, and people that they knew from the area where they lived, their neighborhood, would just disappear every night. And this resulted in significant trauma. And that kind of a thing has been now extended into the ACE studies. We see people in war-torn Africa and growing up in inner cities that are it's really difficult. There's another question. Thank you for that good question. Anonymous attendee, would complex PTSD be equivalent to developmental trauma? You know, yes, essentially it's kind of, you know, trauma is as trauma does sort of thing. Those are two verbiages that actually mean the same thing for most individuals. So yeah, that we say complex PTSD and we often mean developmental trauma. I have another question here. What type of therapy seems to be most effective for ACE-related developmental trauma? Wow, that's a really great question. I'm a little hamstrung because of where I work, because everything we do is permeated with trauma care. I mean, we have a trauma track, we have trauma therapists, we have a trauma physician. You know, obviously seeking safety is an important thing, working through issues that allowing people to have access to this. We find a lot of purchase in our patients with somatic experiencing and EMDR. Now, EMDR, I want to caution people because sometimes we see that as the panacea for everything. Patients come in and they hear about EMDR, they want to do it. People need to be ready for that, because one of the things we do to answer that question is whatever type of therapy that is, we need to access that nervous system slowly, because by really activating that trauma very quickly, they become dysregulated. And that we find is very deleterious to their overall therapy here. So there are many models. We engage in an integrative care model where there are very specific groups, therapists and physicians who are dealing with that. We find body work is extremely helpful, and as I said, somatic experiencing and EMDR, but also processing and sharing in group. The timeline, recognizing it and understanding is very important too. Thank you for that question. Let's see here. If 2/3 of Americans experience at least one on the ACE study, and if one, probably more, what do you think that says about our culture? Wow. And that so many people experience trauma. It's a really great question. You know, I guess it's very subjective. What do I think? I think that if I looked at why we have one, if I look at the ACE study, I suspect it's divorce, because that's probably the one where most people find that there's a score of one. However, all too often, and it's just not, I know I'm probably speaking to divorced individuals here, so I want to be really cautious. All too often, that divorced household, there's a lot of other things that are swirling around that. Not always, but I think that's where we grow into the two or more. Now, what does it say about our culture? Well, I think that not even so much the number, but the fact that it's hidden and that we don't talk about any of the numbers or these traumas says a lot, that we, like a lot of other Western cultures, want to sweep these things under the rug and act like they're not there. So in point of fact, perhaps we need to buckle down on, I don't know, our values in terms of how we treat individuals and treat each other and treat our family members and treat our friends, and, you know, basic kind of kindergarten stuff, I guess. But there is a degradation of some cultural things. So I think it has to be, you know, it has to be brought into play. So yeah, great question. And thank you. I used the 10-question ACE study. Is it possible to obtain a copy of the 14-question ACE study, or is that proprietary? Much appreciation. No, it's not proprietary, and I'd be happy to share. And my email is, if you're ready for this, Donald.Sansom, S-A-N as in Nancy, S-O-M as in Mary, at SierraTucson.com. And if you are so interested, I can get you some of that information to you. And I don't think it's proprietary. I think that we've utilized it elsewhere. There are, however, an easier way to do this. If you look up the ACE study, you may find through several of the very good sites, including some of the sites that Vince Felitti, I think has been a part of. He's had his name involved. You'll find some of the expanded studies. So either way, I'm happy to do that. So, and kind of wrapping up here, I just got a really great thank you, Dr. Sansom, and I thank all of you. We're starting to kind of slow down on what we got. Those are some great questions. And what I wanted to do is that there is a short poll at the end here, and if you wouldn't mind sticking around for a moment to look at that poll and answer it. It really helps us get better, helps me get better, helps C4 get better, and we can all grow together. And I got another thank you. You're all very kind, and I appreciate you participating today. So thank you very much.